Gentlemen, welcome to the Young Physicians Forum. I'm Upul Disanayake. Today, the President of the Ceylon College of Physicians, Professor Arosha Disanayake, is unable to be present here. May we have the pleasure of Dr. Nadeesha Premarathna, who's a young physician. She's a Senior Registrar in Neurology, National Hospital of Sri Lanka, and MBBS and MD. She has worked in the professional unit of Teaching Hospital Premarathna. The topic today is an overview on autoimmune encephalitis and immune-related epilepsy. Over to you, Dr. Nadeesha Premarathna.
Thank you, dear sir, for the kind introduction, and good morning, everybody, dear sir, and the audience. Today, I am going to discuss a bit about this autoimmune encephalitis and immune-mediated epilepsy. It's an overview of the two. So, this autoimmune encephalitis, in the first instance, it comprises a group of disorders where our host immune system produces antigens misdirected way against the central nervous system. So these patients with autoimmune encephalitis, they present with a wide variety of neurological features, but they typically respond to immunosuppressives. So these entities are told to be not to miss diagnosis because there are definite pathogenic targets there, and these sort of patients can come in a variety of manner to separate clinics. They can come to psychiatric clinics, neurological clinics, so on. And with regard to this encephalitis of infectious origin, which is widely prevalent, the autoimmune encephalitis or autoimmune causes of encephalitis, the incidence and prevalence comparably similar, most of the time with the available evidence from the USA and the available countries. So this is a conceptual representation of the neuroimmunology disease spectrum. So the gray box in the upmost area, it highlights the diseases involving the brain, both the infectious causes and autoimmune processes. The large box is dotted, you will see, and it shows the autoimmune processes involving the brain, spinal cord, and the peripheral nervous system. With downwards, the checkered area highlights the paraneoplastic neurological syndromes, and in the center you will see an oblique area showing mixed pathologies with paraneoplastic autoimmune encephalitis. So this is a simple representation of the neuroimmunology. Bit about the history, like how this autoimmune encephalitis came into the minds of the clinicians, is started from the neuropsychiatric manifestations and with the neurosyphilis in the early part of the 19th century, where the clinicians and the scientists have thought about how do these people come with behavioral manifestations, psychiatric manifestations, so on. So they have postulated several hypotheses. One is this immediate toxic effect of the treponema on the neurons and the cerebral cortex, and where they will produce some sort of aberrant functioning in the neurons and the cortex. And then the other hypothesis was the production of antibodies due to persistent chronic infection, producing some sort of, again, misdirected action of the neurons and the cortices, producing psychiatric manifestations. So the early part of the 19th century with the neurosyphilis, the idea was brought about, and subsequently with this encephalitis lethargica, where the people again went on, like how these patients with the prodromal symptoms, after a few, perhaps a couple of weeks after, will present with behavioral manifestations. So they have gone in depth into the pathophysiology, have done brain biopsies also, demonstrated these inflammatory infiltrates in the midbrain, and then postulated possible neuroinflammation is going on. Then subsequently this Sydenham's chorea after this rheumatic fever, and then this Hashimoto's encephalopathy, which presents episodically with coexistent autoimmune thyroiditis, which is pretty responsive to steroids in most of the cases. And then later on, this description of this group of paraneoplastic encephalitis, all of these entities brought about this concept of neuroimmunology to the discussion. So the exact diagnosis of autoimmune encephalitis, of course, has been made in 1938 by this Brewer and the Beaumont, by this characteristic description of a patient with ovarian malignancy who presented with cerebellar degeneration. And later on, this concept was established in 1981 by this John Newsom Davis and the colleagues, where they have treated few patients with Lambert-Eaton myasthenic syndrome with plasma exchange and immunotherapy, and the patients have responded pretty well. So this neuroimmunology or neuroinflammation has brought about into the discussion. So afterwards, this arena has been rapidly evolved with newly developing antigenic targets. So early part of the 19th century, they have detected this NR1, NR2, GAD65, and in early part of the 2000s, this NMDAR, VGKC, the voltage-gated potassium channel complex antibodies, EMPA, and now they have detected this GFAP-alpha, IGLOD5, dipeptidyl peptidase 6 sort of newly coming antibody entities, and these new core symptoms associated with these antibodies. So basically, there are three types of antigenic targets that have been identified so far. The first one is this intracellular, cytoplasmic or nuclear antigens, which is targeted on this HU, YO, MA1, 2, CRMP, those sort of antibodies, which are mostly associated with malignant conditions. The second target was this intracellular synaptic sites, which are that GAD65 and MP5 can be given as examples. Again, those are again associated with malignancies. The third entity is the cell surface and membrane-bound antibodies, which is more prevalent and widely talked about. NMDAR, EMPA, LGI1, Caspar-2, GABA-mediated diseases, voltage-gated potassium channel complex-mediated diseases all belong to the category of these cell surface and membrane-bound antibodies. So these are the three subtypes. And then how do these patients with autoimmune encephalitis present to us? They present with a wide spectrum of neurological symptomatology. One of the most common feature is the psychiatric or behavioral manifestations. They can come with aggression, irritability, mood lability, hallucinations, and marked sleep-awake cycle disturbances. And mostly this is encountered in our most prevalent NMDR encephalitis, and also in EMPA also. In NMDR, these people have a complex phenotype of psychiatric disturbances that can range from mood disorders to cognitive impairment, psychosis, behavioral issues, and catatonia. And in most of the scenarios, these NMDR encephalitis patients come up with psychiatric manifestations and purely psychotic symptoms at the outset. The cognition. The second important area to be discussed in the symptomatology is the cognition, and these people can come with disorientation, confusion, confabulation, and amnesia. And these cognitive disturbances mainly postulated because these antigenic targets are mainly localized to the limbic system, particularly the hippocampus. And so again, these are characterized mainly in NMDR and LGI1 and almost all the other types of antibody-involved encephalitis. Then the seizures. Seizures also occur in almost all types of antibody-mediated encephalitis syndromes, and the frequency and the semiology of the seizures differ in between antibodies. This LGI1 encephalitis I wanted to discuss first because it has a well-characterized seizure profile. Typically occurs in men in between the ages of 5th to 8th decades of life. They will have very frequent focal events with multiple seizure semiologies. And then there is association of this pathognomonic faciobrachial dystonic seizures also. They can have short-lived but frequent piloerection seizures and paroxysmal disease spells, and then more classical temporal lobe events also. And the Caspar-2 encephalitis, they again can have frequent focal seizures and sometimes rare generalized seizures. GABA-mediated syndromes again can have any sort of seizure semiology, but they are more common to come up with status epilepticus. This NMDR encephalitis, which is more prevalent and widely talked about, they again can have a varied seizure semiology, but less frequent compared to LGI1 and Caspar-2 mediated encephalitis. But sometimes when the patients come with purely psychiatric manifestation, it could be the first seizure event that prompts us to the diagnostic possibility of autoimmune encephalitis there. And the fourth symptomatology will be these movement disorders. The NMDR encephalitis, it can present with a wide variety of movement disorders, including chorea, stereotypies, dystonia, and generalized tremors. And then this glycine receptor-mediated encephalitis and dipeptidyl peptidase-like protein 6-mediated variety also can present with movement disorders like hyperreflexia and myoclonus. And this Caspar-2 and IGLOD5, they can have gait disturbances. Dysautonomia is another feature, and this widely prevalent NMDR antibody encephalitis, they can have wide fluctuations in the blood pressure. They can have tachyarrhythmias, bradyarrhythmias, and there could be coexistent orthostatic hypotension, constipation, and abnormal pseudomotor function. Then this diagnostic criteria. So the people have build up diagnostic criteria, basically how to treat patients in the acute setting, because if you wait till the CSF and the serum serologist to arrive, it will take time. So it will delay the patient management. So these criteria, they do not include the CSF or serum neuronal autoantibody profile, but instead the clinical symptoms and then some of the other features like this focal CNS findings, unexplained refractory seizures, CSF pleocytosis and MRI characteristics with reasonable exclusion of the other alternatives. Then we can arrive at a possible diagnosis of autoimmune encephalitis. And then even the definite diagnosis can be arrived in the absence of this neuronal autoantibody panel, in the presence of characteristic clinical scenario with MRI characteristics and CSF pleocytosis or EEG abnormalities with reasonable exclusion of alternative causes. Most of the time, these autoantibody mediated disorders, they present rapidly within days to weeks. But there are instances we have to deal with chronic cases. Sometimes the patients will have symptomatology ranging from 1 to 5 years in the case of this CASPR2, LGI1 and this newly diagnosed IGLON5 antibody syndromes. So this table highlights mainly the antibody-mediated syndromes with the core set of clinical features. Most of them we have discussed already while discussing the symptomatology. For an example, this NMDAR, it presents with prodromal symptoms, psychiatric disturbances, movement disorders, seizures, catatonia with tumoral associations, basically this ovarian teratoma. And the other varieties also this AMPA, GABA, LGI1, CASPR2, they have classical core set of phenotypes. IGLON5, dipeptidyl peptidase 6, all have these set of classical phenotypes, but if the patient comes up with this classical scenario, it's easy to target the antibody profile, but most of the time patients present haphazardly, where we have to use high clinical suspicion to arrive at a diagnosis. This highlights the paraneoplastic entities with NTHU, MA, ampifycin. Most have this element of limbic encephalitis with cognitive changes, and then these seizures, movement disorders, and well-characterized other core set of phenotypes. Anyway, we have to exclude the differential diagnosis at the first instance. It would be this infectious encephalitis foremost, mostly the HSV, and these space-occupied lesions in the brain, especially the temporal lobe gliomas, sometimes neurodegenerative diseases like Creutzfeldt-Jakob disease, metabolic encephalopathies, and sometimes patients with frequent refractory seizures can have early MRI characteristics misleading to a diagnosis of antibody-mediated encephalitis. So we have to anyway exclude differentials before going into the therapy. The diagnostic workup starts with the CSF studies first, because we have to anyway exclude infectious pathologies before starting immunotherapy. And then these people can have CSF pleocytosis with high protein level, high IgG, and CSF oligoclonal bands. When we have the capability, we have to always go for CSF and serum neuronal autoimmune panels in order to characterize the ideal antibody-mediated syndrome. Because in certain scenarios, like in NMDR and GFAP antibody-mediated syndromes, the CSF will be more sensitive. But on the other side, these paraneoplastic conditions, LGI1 and aquaporin-mediated disorders, the serum will be more sensitive. In whichever the condition, if we have the capacity, we should go for both serum and CSF neuronal autoimmune panels. If we don't have serum, we should go for CSF at least, because most of these patients, they can have syndromic overlap. And then the other blood tests we should order in order to exclude the differential diagnosis mainly. And then the imaging, I want to discuss this MRI first. This MRI T2 FLAIR imaging, if that shows this characteristic bilateral medial temporal hyperintensities, it will aid to the diagnosis, at least for the definitive diagnosis. But most of the instances, we will not be able to see this limbic encephalitis in the MRI. Most of the time, the MRI would be normal. But in certain scenarios, they will show other anatomic subtypes of this autoimmune encephalitis. Here, the panel A shows the limbic encephalitis, B, the cortical or subcortical encephalitis, C, the striatal involvement, D, the diencephalon involvement, E, brainstem, and F, this meningoencephalitis. If they have the characteristic clinical spectrum with the MRI, pending the neuronal autoimmune panel, we can of course characterize the antibody-mediated syndrome then and there. If the patient comes with a doubtful clinical scenario highlighting the possibility of autoimmune encephalitis, if the MRI is negative, if we have the capacity to go for this fluorodeoxyglucose brain PET imaging, that would be ideal because that is more sensitive and specific. It will detect early changes that could be missed in the MRI. This bilateral mesial temporal lobe hypermetabolism in most of the autoimmune encephalitis cases, and sometimes in anti-NMDR encephalitis, there could be bilateral occipital lobe hypometabolism. So those will aid in the diagnostic workup if we have the capacity to go ahead with the brain FDG PET. EEG in most of the instances will show focal or diffuse slowing. There could be periodic discharges, and in extremely rare instances, we might be able to see this extreme delta brush, which is depicted in this photograph. Therapeutic strategies mainly involve the immunotherapy. So if once we have excluded the infectious etiology, if the diagnostic suspicion is high, we have to always start immunotherapy early because delaying it will be hazardous. So it starts with the high dose of corticosteroids, methylprednisolone 1 gram per day for 3 to 7 days at least. It responds, most of the antibody-mediated encephalitis responds at least partially to steroids. But remember that malignancy-associated ones, the paraneoplastic encephalitis, poorly respond to immunotherapy. But out of the other immunotherapy options, for the steroids, they will respond. Especially now in this era of these immune checkpoint inhibitors that are used in the malignant conditions, there's accelerated autoimmune encephalitis that is being developed. So in those scenarios, these steroids will work. And this paraneoplastic autoimmune encephalitis basically T-cell mediated. So compared to the other immunosuppressives, the steroids have a bit of a place. So the second option would be intravenous immunoglobulin with 2 grams per kg dose divided for 2 to 5 days. It again hastens the immunomodulation, but there's this risk of thromboembolism there, and these malignant conditions poorly or hardly respond to IVIG. The third option is the plasma exchange, which is done every other day, divided like at least we have to have 5 cycles that should be given to the patient, and it will again hastens the immune recovery and will have less side effects compared to IVIG and steroids, but mainly the side effects are related to the line infections, line thrombosis and so on, but they can have these circulatory disturbances including electrolyte disturbances, hypotension, so on. If the patient poorly responds to one of these immunomodulatory therapies, we can of course combine these at the outset. We can observe the patient for further 2 to 4 weeks. If the patient remains refractory, does not recover well to the first line therapies, we can of course go for second line treatment. Now these newly available biologics, this rituximab and then this bortezomib, tocilizumab, those combinations, when we administer to the patients, they recover fairly well for the second line agents. And for the long term recovery, this MMF and azathioprine we can prescribe. And the rest of the workup, we should target the symptomatology, and then we should not forget the malignancy screening if we have not done so far, including the CECT, chest, abdomen, pelvis, and a whole body PET if that is available. So that's about this autoimmune encephalitis. Then a bit more about this immune-mediated epilepsy, because it's a little bit of a new entity. Now, most of the people with epilepsy, in certain scenarios, they become refractory to usual anti-epileptic drugs, even if their compliance is all right. Sometimes youngsters present with refractory seizures of recent onset, perhaps less than 1 year, and they are not responding to any of the anti-seizures drugs. Sometimes if we dig through them, in the symptomatology, they might have mild symptoms of autoimmune encephalitis also, at least 1 or 2, like the subacute progressive cognitive decline, psychiatric symptoms, prodromal symptoms, autonomic disturbances so far. So in those instances, this immune-mediated epilepsy, the hypotheses have been built out, and it was accepted in 2017 by this International League Against Epilepsy. And this importance of these entities, because most of these patients respond pretty well to immunotherapy. And we can use immunotherapy both for the diagnosis and then for the management. Diagnosis is mainly based on the clinical phenomenon and then imaging characteristics, CSF characteristics, and this neuronal autoimmune panel. So if we have the doubt of immune-mediated epilepsy,
like in which scenarios should we go for neuronal autoimmune screening, autoimmune panel screening? This for the question of this problem is given by this predictive scoring system. It's this antibody prevalence in epilepsy and encephalopathy, APE2 score, which is mainly a predictive model for this prevalence of neuronal antibodies. And basically, this scoring system, it has few domains. If the patient scores 4 or more, the diagnostic doubt remains. So we have to, of course, go ahead with the further investigations to establish the diagnosis of immune-mediated epilepsy. So the domains involved in this APE2 score, mainly with the symptomatology, as we discussed, this new onset, rapidly progressive, refractory seizures, and some of the autonomic disturbances, neuropsychiatric symptoms, history of malignancy, prodromal symptoms, these facial-brachial dystonic seizures or facial dyskinesia, CSF characteristics, MRI characteristics, those are the domains in this APE2 score. Each of the domain will be given a separate scoring. So if the patient scores 4 or more, then we should, of course, go down the pathway. But if the score is less than 4, we can forget about this. This should not be immune-mediated epilepsy. We might be dealing with something else. But if the score is 4 or more, then of course we can go ahead with neural-specific antibody evaluation. Once we have done that, if the antibodies are positive, then we can conclude it's definite autoimmune epilepsy. But let's think that we do not have the capacity to go ahead with this antibody evaluation. In that instance, we can directly start immunotherapy and see. If the patients recover at least 50% for this immunotherapy, then we might be dealing with a case of probable autoimmune epilepsy. Even if the patient does not respond to the initial immunotherapy workup, but the patient is having a score of above or more 7, then it should be immune-mediated epilepsy anyway. Possibly the patient might need up the ladder, the immunosuppressives of the more potent immunosuppressives. Even if the patient is having marginal scores like 4 to 6, although the neuronal specific antibodies are negative, or if we do not have the capacity to go ahead with the screening, we can do the immunotherapy, we can start the immunotherapy and see. Even if the patient does not recover, we might be dealing with a case of immune-mediated epilepsy. So we should not miss that diagnosis. And then there are other scoring systems like this RIDE2 score. Basically, these are being built up to see whether these patients respond to immunotherapy or not. The domains are basically similar with APE2 score. Anyway, if the patient scores more or less 7, that is more sensitive and specific, we should start immunosuppressives and see. So this scoring system guides for the prediction of the positivity of neuronal antibodies, and then for the start and proceeding with the treatment of immunosuppressives also. So the treatment is more or less similar with the acute scenario of autoimmune encephalitis, starting with high dose of steroids, IVIG and Plex, and then we can combine with second-line immunosuppressives like rituximab, cyclophosphamide, and then later on for the long-term remission, we can combine with mycophenolate, azathioprine, tailing off the steroids. And for the anti-seizure drugs, this levetiracetam, oxcarbazepine, and lacosamide are the preferable antipsychotics. But even though we treat the patient aggressively, we might be dealing with cases of very resistant, aggressive, chronic cases of immune-mediated epilepsy. So basically that is what I wanted to discuss today, and these were my references. And thank you for your patience and listening. I'm happy to take over the questions.
Thank you, Dr. Nadeesha Premarathna. The forum is open for questions.
Now, you said that patient with epilepsy, central epilepsy, might need to think of possibility of, immune encephalitis. What about these patients coming with acute psychotic episodes, or acute psychiatric illness? Do you think that we should, think about autoimmune encephalitis in these patients as well?
Yes, sir. That's what I was discussing with this NMDR encephalitis. In most of the cases, in the acute setup, they come with purely psychotic manifestations. And it will be the first seizure sometimes which triggers this possibility of autoimmune encephalitis. But we can characterize autoimmune encephalitis even though they present with pure psychotic manifestations, because usually they will have a complex psychotic pathology that will range from mood disorders, sometimes catatonia, and then behavioral disturbance. They will have a complex phenotype with regard to acute psychotic illnesses. But that again will not be crystal clear. But in most of the time in the youngsters, we should suspect autoimmune encephalitis. We should anyway go down the path, exclude infectious causes and think about it.
Next, my second question is how sensitive is this detection of, how you check the antibodies in the CSF, I suppose?
Yeah.
How sensitive are these, because,
Yeah,
what is the sensitivity of these
sensitivity
antibodies?
can range from 70 to above 70-80%. Like we had to always combine the clinical scenario and the available investigations and the autoimmune profile, because even if the autoimmune profile is negative, if the clinical suspicion is high, we can't disregard the diagnosis. Sometimes there are seronegative cases and then new autoimmune antibodies are coming up. So we should always be based on the patient and then decide.
That we don't have, usually we don't have facility to do most of the patients, we don't have facility to do the antibodies. So do you, if we suspect, do you think that we should do a CSF in these patients?
We should do a CSF basically to exclude the infectious causes. Then of course the clinical suspicion is high, we can start immunotherapy and see. So if the patient recovers, possibly that will aid in the diagnosis. Even the immunotherapy per se can aid.
Dr. Premarathna, once you start the treatment, how long do you treat them for? Say, a possible autoimmune encephalitis causing a psychiatric manifestation?
Yeah, if we are towards the diagnosis of autoimmune encephalitis, we should continue the treatment for a little longer time period. So usually for these immunosuppressives, we might have to continue for at least 1 year. And sometimes in certain scenarios, it will be little longer. And the responsiveness of the patients to these immunosuppressives again vary depending on the antibody profile. But most of them, in about 1 year, if they don't have any relapses in between, we might be able to tail off the immunosuppressives. But if they do develop any relapses, we might have to escalate the immunotherapy in between, and then we might have to continue immunosuppressives for longer.
What is the Sri Lankan scenario? Do you see a lot of autoimmune encephalitis in Sri Lanka? Do you have facilities to diagnose this?
Yeah, I think with this autoimmune encephalitis, this new knowledge is being built up and it is being investigated. Even the researches and studies are being done in the country. So most instances, we detect new cases of autoimmune encephalitis. We treat them and they respond fairly well. Mainly these people without any tumoral association, they respond pretty well. And in NHSL, of course, we screen for these autoimmune panels, but I think in the remote areas, if we have the capacity to do in the private sector, we might, of course, go ahead. But with the crisis, I don't think we all will have the facilities any longer.
Thank you very much. Any questions? In the absence of any questions, we'll present the certificate to Dr. Premarathna.